Welcome back. Today we'll be discussing chapter 26, which covers soft tissue trauma. So this is what we see on a lot of our trauma calls is something that will affect the soft tissue. Whether that's blunt force or penetrating trauma, we typically have to take care of the soft tissue as part of our care of most trauma patients that we see. So we do have a lot of topics to get through. This will be kind of a longer presentation, so we will start talking about soft tissues and the anatomy and physiology behind it. We'll then go into closed wounds and open wounds, how to dress those wounds and bandage them, how to treat specific types of open wounds. We'll then talk about some burns that we'll see, and then electrical injuries that we can see with soft tissue. So let's jump right into soft tissue. We're going to start with some anatomy and physiology review and then go a little bit further. So what is soft tissue? That's really includes most of our body that's not actual organs or bones. So we include the skin, fatty tissue, muscle, blood vessels, connective tissues, membranes, glands, and nerves. So that's a lot of stuff that we have to include with soft tissue, which is why we typically will see soft tissue being injured on most of our traumatic injuries. You have to get through soft tissue to really hurt anything else. So that's the first layer that you have to hurt in order to hurt anything else, which is what we get called for. So like I said, soft tissue injuries are very, very, very common for us to see. So right here's a diagram of how everything's laid out. You start with your skin, then you have a layer of fat that will help insulate and protect us a little bit. Muscles underneath the fat, throughout the fat and muscle, you have some blood vessels and nerves running through there. After your muscle layer, you usually have some membranes, connective tissues. You will have bones between your muscle layers, and then your nerves run through everything as well. So a lot of this is all intertwined. But we do have the outermost layer, which is skin, and then fat and muscle behind that, and then the rest of the stuff is really intertwined with all of those layers. So the skin is an organ. It's also its own body system. So it is the largest organ that our body has. The body system that the skin forms is the integumentary system, and it is a very, very important system to keep our body safe. The best thing that the skin does is it provides protection from us from outside pathogens. If you can't get through our skin, you can't get into our body. So that keeps 99.99% of pathogens out of our body. It also will help us keep our water in. So it keeps water or things out, and it keeps things in. So it will help with our water balance. It keeps water in, and it can help excrete the water out if we need to get rid of something, which in turn gives us temperature regulation. So when we sweat, that will regulate our body's temperature. It can cool us down a little bit. It also helps with excretion, because when we sweat, we can excrete some waste products. And then lastly, it provides a little bit of shock absorption when we take some sort of blunt force trauma. It will hopefully make it so that our internal organs don't get as impacted because we take some of the shock with our skin. As far as the skin goes, it does have 3 layers. The epidermal layer is the outermost layer. It's made of dead skin cells that will be brushed off and then replaced with other dead skin cells. You then have your dermis, where you have your live skin cells, and that's where you also have most of your other structures like your nerves and some capillaries, all that stuff is in your dermis. Then your subcutaneous layer is where you have the fat and some larger blood vessels, larger nerves. There will be a diagram in the next slide that will show all this. When we have a traumatic injury, we have to refer to it as a closed or open injury. And that really just says, did we penetrate the skin or not? If we did, it's an open injury. If we did not, it's a closed injury. So when we say that we have an open femur fracture, that means that the femur is actually sticking through the skin, versus a closed femur fracture, that means the skin is completely intact. So you will hear that quite a bit throughout trauma, where we refer to open and closed injuries. So, like I said, there's a little diagram that shows the skin. So we have our epidermis right here. It's our outermost layer. Like I said, most of that is dead skin cells, which is the topmost layer that gets sloughed off and then replaced with live skin cells. Your dermis right here has all your different glands. The hair follicles start in your dermis. You have a little bit of blood flow and a little bit of nerves. You also have your sensory receptors that kind of go between your dermis and epidermis. Then down here in your subcutaneous layer, you have your nerves, some fatty layers, and you have your veins and arteries running through here. So when we have trauma to the skin, we can refer to it as what layer of the skin affected. So you could have a laceration all the way down to the subcutaneous layer, and that's usually when we see a little bit of fatty tissue. Or you could just have a superficial laceration, which is usually only affecting the epidermis, maybe the dermis as well. So going into closed wounds. So closed wounds typically are caused by blunt force. Usually if it's a penetrating wound, that's going to be an open wound. So typically these are blunt force injuries that cause closed wounds. Like I said, it means it did not break the skin, so there's no way for the no pathway to the outside from the injured site, which is good because that means that we won't get the pathogens going into our body through the opening in our skin as easily. Just because the skin is not broken, that doesn't mean that we don't have extensive damage below the skin though. So that's where it becomes a little bit of an issue for us because we can't fully see what's happening. We just have to guess, but we have our assessment tools with us, which we make our guess more accurate. Yes, we do not have an x-ray with us on the ambulance. We don't have a CT scanner, but a good thorough assessment should be able to tell you a good idea as to what's happening underneath the skin. So closed injuries, they can be very, very minor, but they can be life-threatening and can cause death. Yeah, there's a lot of stuff we'll talk about with chest trauma that are closed injuries, and they will cause you to die because of what's happening inside of your chest. So that's why we have a whole chapter about it. So closed wounds can be very serious, and it's harder for us to gauge these injuries because there's nothing on the outside that we can really see except for maybe a few signs or symptoms such as like bruising popping up. So that's where we really have to rely on our assessment ability because we don't have the grotesque bone sticking out of the skin, or you don't have the obvious bullet wound that you can see, oh, something went in here and damaged a bunch of tissue and they're bleeding heavily out of it. We have to use our assessment to find out what's actually happening internally. So a little bit of terminology. A contusion is what most people call a bruise. Another word for that is ecchymosis. I usually go with contusion, but you might hear ecchymosis thrown out there every now and then. Then a hematoma, it's very similar to a contusion. It just involves larger blood vessels. So a contusion is when usually capillary vessels burst and blood flows out of the capillaries. So that's what you're seeing with a bruise is the blood that came out of a capillary and it's just sitting in your interstitial space now. Hematoma, usually you burst a pretty large vein. So there is a lot of bleeding going on with a hematoma, which is, yes, it's similar to a contusion because same pathophysiology behind it. It's just at a much larger scale. So it's usually a lot darker of a color that you'll see versus a contusion, and it's usually much bigger, so it's much more widespread. Usually contusions are relatively localized. So you will see those words thrown around every now and then. Just know a hematoma is usually a bigger version of a contusion. You also have what we call closed crush injuries, and that's when we have a crushing force that goes onto our body, and it usually will rupture organs and or blood vessels. So we just put so much pressure on our body that things start to burst because they are being crushed. You also have blast injuries. So that's where we have a percussive wave that usually will cause damage internally, but we won't see open wounds. So that pressure wave will cause quite a bit of internal damage, and it will rupture a lot of our organs, both hollow and solid. And then also following up with blast injuries, you can have penetrating trauma from shrapnel coming away from the blast. So blast injuries are very significant because they can cause closed and open injuries, but in my experience, a lot of the damages come from the closed injury side with the pressure wave that will just rip through your internal organs and just burst them open from all the pressure. So here's some of the closed wounds that we can see. We talked about contusion or bruising. You can have a rupture of a hollow or solid organ. You can have a crush injury with no open wound, and you can have internal laceration. Internal laceration typically comes from a fractured bone, and the sharp sides of a fractured bone can lacerate the organs that the bone is meant to protect. So that's why we have to stabilize our bones when we see a fracture of a bone, so that it doesn't lacerate the surrounding tissue. That's why we'll talk about that extensively in musculoskeletal trauma and how we can effectively splint things. So bruising, as we talked about, is free-flowing blood. It's usually coming out of a capillary. So that typically means that you had some sort of injury that caused a capillary to rupture. That's why if you get hit, say with a fist, you'll probably bruise thereafter because the force of being hit was so much that it burst those very small and delicate capillaries. So that's why we see bruising. So whenever you see bruising, you have to think that there was some sort of force large enough to rupture blood vessels. So that's why it's a very serious finding in trauma, because very early on, bruising only usually shows up if there is significant injury. Bruises typically take a little bit of time to develop because it has to bleed for a long time. The blood has to reach the surface of the skin before us to see it. If you have bruising that shows up immediately, that means that you probably ruptured a larger blood vessel, which means you probably had a lot more force than normal. So this is where we really have to be considering our mechanism of injury and think what could have caused this and what other injuries might we see because of this amount of force. And you do have to keep in mind that when there is a crush injury, it's hard to really know what happened underneath because there could be so much going on with a crush injury. So, as always, our first step with patient care is take your appropriate personal protective equipment. And just like with all the other instances of internal bleeding that we've been talking about, you have to be prepared for the patient to be vomiting blood. That's hematemesis. So be prepared for that, and that's why we need to have our full PPE on, because we don't want them to projectilely vomit blood and it get on all over us and get into our mucosal membranes. Then, as always, manage your ABCs. If you see any issues with that, go ahead and take care of them there. And then you always have to assume the worst. That's kind of the theme of our care. We always treat for the worst possible scenario. And since internal bleeding is hard to identify, we always have to assume that there is some. So manage the patient just like you would if there was internal bleeding. If you start to see signs of shock, go ahead and treat for shock. So again, we can't tell if there is internal bleeding or not, and we always treat to the worst possible case scenario. So always treat for that. Anytime that we have internal injuries, you should always be thinking about possibly involving ALS, at least for an assessment of these patients. When you have soft tissue injury, if you feel like there might be some musculoskeletal trauma, so you might be a fracture, then we're splinting that area. Again, we'll cover that in musculoskeletal emergencies. Make sure that you know that they might be vomiting suddenly, just like we talked about. They have a tendency to do that, especially if they have internal bleeding, and then continue to reassess the patient. All right, going into open wounds. Open wounds are a little easier for us to assess just because we can see what's happening. The danger, though, with open wounds is you have to know that there could be a lot more damage underneath than what you're actually seeing on the outside. So treat it like you would a closed wound. Just because you see the open area, don't neglect the tissue underneath that you can't see. So don't get that tunnel vision of, oh, they have this really bad wound to this one area, let's bandage this up, and then forget to assess the rest of the patient, or forget that there could be damage beyond that open wound. So the different types of open wounds that we see will have abrasions, which are scrapes, lacerations, which are smooth cuts, penetrating trauma and punctures, so that's where we have something actually enter our body, whether it stays inside our body or comes back out. Avulsions, which an avulsion is a tearing away of skin, but you still have it connected somewhere. And then amputations, which is where you lose a body part somehow. It could be a finger, toe, it could be an arm or a leg. Can't really be a head, because you won't, if you amputate your head, you're going to not be alive anymore. But amputations are pretty well understood by the layperson. You also have open crush injuries. So that's where we have so much brute force that it splits our skin open. That's usually significant tissue damage. You can have bite wounds, which the big danger that goes with bite wounds is bacteria, because usually bite wounds have saliva associated with it, and saliva has a lot of bacteria in it. And then blast injuries, as I said earlier, can turn into open wounds, usually with shrapnel. So when we have an open wound, definitely use your full PPE. You want to be using gloves, mask, goggles, gown if you have it and you have time to put it on. Isn't the worst idea in the world. So use a lot of your PPE with open wounds. You have active blood usually flowing out, and it could be with some force behind it, like if you have an arterial bleed. And think, does an open injury affect the patient's airway or breathing? A lot of times this depends on where the open injury is. So if you find an open injury and it's affecting the airway or breathing, that's where we're taking care of it in our ABCs. So I probably sound like a broken record to this point, but when we're caring for open wounds, use your full PPE. Next, we want to expose the wound. So get the clothing off of it, cut it away, remove the clothes, whatever you need to do. Make sure that you're dealing with just skin. You then briefly clean the surface of the wound. We usually do this by irrigation. We're not getting in there and trying to scrub it with alcohol preps or anything like that. So irrigate it, get any gross matter out of there, like any dirt or whatnot, get that out of the wound. And then we control the bleeding. If you need to review how we control bleeding, go ahead and watch the bleeding and shock presentation. Then whenever we have a serious wound, you have to be very cognizant of them going into shock. So if you suspect shock at all, go ahead and treat them for shock. Again, when we put a dressing on a patient, you need to bandage it so that we have that dressing in place, and then provide supportive care. So I know that we covered bandaging and dressing wounds during bleeding and shock. We're just going to do a very quick review of that. So terminology: a dressing is any material that's applied to a wound to control bleeding and prevent contamination, versus a bandage is what's used to hold the dressing in place. So a dressing is what actually goes on the wound, and then a bandage is what goes over top the wound. That's why a lot of people get confused, because they think like a Band-Aid bandage, you're like, well, we apply that to the actual wound, but the bandage part of the Band-Aid is the sticky material. The dressing is that little gauze pad in the middle of the Band-Aid. So a Band-Aid is a dressing and bandage in one, but the material you actually see on the outside is the bandage, which is why they call it the Band-Aid, because that's the part that you actually see on the outside. So we do have quite a different array of dressings and bandages. So you need to use the one that is most appropriate for the wound. So we have universal dressings. That's just a large gauze pad that you can put manual pressure onto. We can use that for profuse bleeding and large wounds. You have a pressure dressing, which we talked about in bleeding and shock. That's where you actually put a little bit of pressure behind the dressing with the bandage, and then you have an inclusive dressing, which we're going to talk a lot more in chest trauma. And an occlusive dressing is what we use to form a airtight seal so air can't get in and out. It's very, very useful for, like I said, chest wounds. It can also be used with large neck wounds that you might have air trying to get into the neck, and it can be useful every now and then with abdominal wounds. But we mainly use occlusive dressings for chest wounds. So as I said, when it comes to selection, you have a ton of different sizes and materials available. For dressings, you usually use gauze, and gauze ranges from 2 inches by 2 inches, so a nice little small square, to 10 inches by 30 inches. So that's usually the array of sizes we carry on the ambulance, and that's quite the range. So select the appropriate dressing to the size of the wound. If you have a very small wound, use a very small bandage. If you have a very large wound, use a very large bandage. There is one quick note I'll make, and this is easier to show in person. Usually the smaller dressings, so like the 2x2 and the 4x4 gauze pads, are made up of very thin fibers that are all woven together, versus the larger ones, so like your 5x9s, your 8x10s, your 10x30s, those are more absorbent pads. So when you have a larger injury, I tend to go for the larger pads because they absorb a little bit better in my opinion. But also when you remove them, the smaller sizes, that's very like the interwoven fibers, those actually tend to stick inside of the wound a little bit more. And so when you remove it, it can cause a little bit more issues for actually removing that material out of the wound, versus the pads don't come apart as easily. That's, again, one that's easier to show in person. So if you got confused at how I explained that, feel free to see me in person. It's very easy once you actually see it in person to understand the differences. In terms of bandages, we usually use what's called roller gauze, and roller gauze is measured by how long it is. And again, we have a wide array. I've seen it all the way down to about 3/4 of an inch long, and I've seen it all the way up to 5 to 6 inches long. So yes, size selection is important, and it's usually pretty obvious. You want a dressing that will cover the entire wound, and then you want bandaging that will go a couple inches above and below your dressing. So it's usually easy to size when you see wounds in person, but do keep that in mind that we have a wide range of dressings. Just make sure that you cover the wound in its entirety. So right here is a picture of someone applying a bandage to a dressing. So you can see right here we have the underlying dressing. This looks like maybe an 8x10, and this is one of those pads I was talking about. And then this is the roller gauze that you roll around the arm. So for dressing open wounds, again, PPE, expose the wound. We probably want to irrigate the wound just to get things out of it that shouldn't be in there. And it's important that we cover the entire wound with our dressing, and then cover the entire dressing plus some with our bandage. We control the bleeding with direct pressure. You can use a hemostatic agent if needed, and if none of that works, then we go to a tourniquet, which again we talked about with bleeding and shock. And the only exception to this is if you need to apply a hemostatic agent later, but for general rule of thumb, once we apply a dressing, we do not remove the dressing. You just put more dressings on top. So when you bandage open wounds, make sure that you don't bandage too lightly or too tightly or too loosely. When you're done bandaging the wound, do not leave loose ends. Either tuck it underneath itself or tie it down. And do not cover the tips of fingers or toes, just because we want to see if we are losing circulation in those areas. So we need to make sure that's not turning purple or anything like that. So we want to be able to see the distal ends of our phalanges. And then cover all edges of the dressing. So you want to be above and below. I usually go about 1 to 2 inches above and below all the dressings. Alright, so going into treating very specific types of open wounds. So the most common form of open wound that we see are usually abrasions and lacerations. So this is the basic wound care that we typically are going to do. So it's follow what we just were talking about, irrigate the wound so that we don't have wound contamination, hold direct pressure, use a pressure bandage, and that should stop most of the bleeds. Once it's stopped, always make sure that you check pulse, motor, sensation function below the injury just to make sure that we didn't shut down the artery completely with so much pressure. If you need that much pressure to stop a bleed, then it's warranted, but typically as long as it's not an arterial bleed, we don't need so much pressure that we restrict all blood flow. As far as penetrating trauma goes, we can't see into the body, so we can't know for sure how deep the object actually is, especially if it's an impaled object. If it is still stuck inside the body, do not remove the object. Just go ahead and try to stabilize the object so it won't move around anymore. Check for any exit wounds. Exit wounds are oftentimes a lot more traumatic than entry wounds. Entry wounds are usually small. Exit wounds are usually very large. Remember that bullets can fracture bones as they enter the body and as they bounce around the body. So you might have a lot of fractured bones. Fractured bones, as we know, can lead to slicing other tissue around the bone because the bone is usually very sharp. And remember that cavitation is a very significant part of penetrating trauma. So if you have a bullet enter the body, cavitation will cause a lot of tissue damage that you won't immediately think about. Stab wounds, if they are in the extremities, are a little bit less serious usually, but a stab wound in any part of the trunk or the neck are considered very serious because we could be cutting through a major organ there. So stab wounds are a little bit dependent on the location, but most of them are considered pretty serious. As far as treating penetrating trauma goes, provide supportive care of reassuring the patient. Make sure that you see all the wounds. So this is where we have to do a full physical assessment and inspection of the patient. Take their clothes off. You cannot do a full thorough assessment without exposing the patient's skin. So make sure you see all of the entry wounds and you look to see if there are any exit wounds anywhere. And exit wounds could be in a place that you don't immediately think about because especially if it's a bullet, bullets will bounce around and might exit well away from where they entered. Request an ALS intercept. If you think that the penetrating trauma affected the spine, take the spinal precautions as needed. Transport the patient very expeditiously. These are patients that we don't want to stick around on scene. And think about where the penetrating trauma happened and what organs might be involved. This is why knowing our anatomy and physiology is very important at this point. That's why we covered it in one of the first chapters we did, and we've been reinforcing it ever since, because now we have to know where all of our anatomy is, so that when you see a bullet wound to the, say, right upper quadrant of the body, you have to think, of the abdomen, you have to think the liver might be involved there. Or if you see it on the left upper quadrant, you have to think the spleen might be involved. So knowing what anatomy is there will help you greatly in being able to take a good idea as to what organ might be involved and how that might affect the patient. So right here you see a gunshot wound to the right flank. So knowing that that's where the gunshot wound is, what organ do you think might be affected here? So hopefully you're thinking liver, and if we know the liver sits there and we know the functions of the liver, you have to think that there's a lot of blood loss happening there because the liver has a lot of blood circulating through it, because the job of the liver is to kind of cleanse the blood. So we have a lot of blood flow going through the liver. So we have to be very, very cognizant that this patient will probably go into shock because they have a significant internal hemorrhage going on. You can see that there is some external bleeding, but you have to think this person probably has an incredible amount of internal bleeding going on. So again, if we have an impaled object, do not remove the object, and that because that might cause very severe bleeding. I don't know if you guys remember Steve Irwin. He got impaled by a stingray, and he didn't die until he pulled the stingray out of his body. A lot of times when we remove an object, we cause a lot of bleeding because that object is what is actually sealing the wound at the moment. So if an object say goes into your aorta, it's sealed your aorta from bleeding because it's taken the place of the wall that it ruptured, and it seals that wound off. When you take it out, you now have a huge hole in your aorta, and you will exsanguinate very quickly. So this is why our general rule of thumb is to not remove impaled objects. There's only 3 instances where we as EMS can remove an object that's impaled. First one is if it's impaled in the cheek, and only if it's impaled in the cheek in a way where we can see both ends of the object. So we can see both ends of the object and there's no further tissue damage that would be involved with us removing the object, then you can take it out of the cheek. The other 2 times we can remove impaled objects is if they are in cardiac arrest and the object is preventing effective CPR. So if they got impaled through the chest and you can't do chest compressions because of the impaled object, then you can go ahead and remove it. And then the next one is if you have an impaled object that is causing some sort of airway obstruction. If it's causing airway obstruction, they're going to die from the airway obstruction anyway. So get it out of the airway and then try to manage the patient. As far as treating impaled objects, expose the area. That's a general rule of thumb for any type of trauma that we see. We need to expose the area so we get a good assessment and we get good treatment of the area. Try to control bleeding with direct pressure, but not at the expense of moving the object around. Then stabilize the object with bulky dressings and tie that nice and tightly around so it shouldn't move around too much. And be very careful when you're transporting these patients. I would rather get to the hospital a couple minutes later and have a slower, smoother ride than to get there 3 minutes earlier but be bouncing around everywhere and moving that impaled object around. So having a nice, slow, stable ride is a little bit more important than speed with impaled objects. Give general treatment for shock, make sure the patient doesn't move around, and then transport and provide reassuring care. So right here you can see how they have bulky dressings or surrounding this stick, and then they put a bandage around those bulky dressings. So going back to impaled objects in the cheek, again, this is the one time that you can remove an impaled object without it being an airway obstruction or it preventing you from doing CPR. So the instructions for removing an impaled object in the cheek. Make sure that the impaled object doesn't go further down the oral cavity, causing an airway obstruction. If the cheek wall is perforated, a lot of bleeding into the mouth and throat can cause nausea and vomiting, so be very cognizant of that. And keep in mind that putting pressure on the outside of the wound will not stop blood from going into the mouth. So you have to put pressure on both sides after we remove this object. Make sure that you can see the perforation and that you can see both ends of the object that's impaled. If you cannot easily remove the object, leave it in place. But if you can see both sides and you can remove it easily, go ahead and remove the object. Here's a picture of an object that would be impaled into the cheek, such as a pencil. After you've removed it, position the patient to allow for drainage. So kind of tilt their head so that the side that was injured is facing down so that blood will drip out of their body, so it won't go into their mouth. If you do it the opposite side, it's going to drip into their mouth and maybe down their airway. Keep their airway intact, make sure blood's not getting into their airway. Dress the outside of the wound, and you can sometimes put gauze on the inside of the wound just to kind of collect some of the blood that's going to be draining into the mouth. So when you have an impaled object in the eye, the number one goal is to prevent the eye from moving around. If we move the eye around with something impaled in it, then you're going to cause more damage. So our big goal first is to stabilize the object and then provide a little bit of rigid protection so it doesn't move around. So as you can see here, there's an object in the eye, and they put 2 roller bandages on either side, so that will stabilize the object so it doesn't want to tend to move around on its own. They then provide the rigid protection, so a cup is usually an okay option to use, and then you use a roller bandage to secure that in place. One thing you have to keep in mind when you are dealing with eye injuries, you should be covering the other eye so that the patient's not tempted to be looking with the other eye. Eyes move together, even if one is injured. So if you have the opportunity to look out of the undamaged eye, if you're looking and then you move your eye at all, the other eye is going to move with your uninjured eye. If we move the injured eye with the object in it, we're going to cause a lot more damage. So we'll pretty much usually just have people dress and bandage the uninjured eye. If you have another means of having the other eye covered, go ahead and cover it, but you want to explain to them to not open up their eye, to not be looking around, and just stay nice and calm. So a lot of emotional support goes with this because our goal is to not have the injured eye move. So talking and reassuring the patient will help a lot when we're talking about that. So as far as avulsions go, avulsions are pretty gnarly injuries a lot of times. This is where we have a tearing away of skin, but it's still intact at one point. So you can see right here, we have the skin is torn away, but still attached right here. And the nice thing about avulsions is a good amount of time they can reattach the skin. So you can see right here, skin was folded back down and stitched back into place. So that's the nice thing about avulsions, is they're usually relatively treatable at the hospital, usually. So when we have avulsions, you want to clean the wound surface. Try to fold the skin back into a relatively normal position. We're not securing it back in place, but we want to try to cover as much of the exposed tissue as possible. And then you want to dress the wound and bandage the dressing. Typically, there will be a significant amount of bleeding here, but it's typically venous and capillary bleeding, so it is relatively easy to control with manual pressure. If the avulsed part is completely torn away, try to save the avulsed part in a sterile dressing and then keep it moist with saline. Sometimes they can reattach the avulsed parts at the hospital, sometimes they can't. So keep that in mind, that if it's completely torn away, try to save as much of the tissue as possible. So when we have an avulsed tooth, I know this isn't a soft tissue injury, but I wanted to cover it real quick. So an avulsed tooth, you actually can re-implant these at the basic EMT level, and this can go a long way in keeping the tooth. So the patient might be able to actually salvage this tooth if you do your job correctly. So always remember, hold the tooth by the crown, not the root. So the crown is the part that you should see if the tooth is in your body. That's the part that's meant to be exposed to the world. So try not to touch the root, which is where a lot of the connections to the tooth are. Try to quickly rinse the tooth off with saline. Do not brush off or clean the tooth of tissue. If there's tissue attached, keep that tissue on there. The hole in the mouth might have some blood clots in it, so try to remove the clots from that socket and suction them out if you need. So they might be deep where you can't manually pull them out, so try to suction them. I will let you know that is usually incredibly painful for the patient, so try to explain to them why you're doing what you're doing. Say that the only way that we can salvage this tooth is if we do this, so it's going to hurt quite a bit, but hopefully this will help your tooth be able to be reattached so you don't lose it permanently. You then put the tooth back into the socket firmly and hold it with digital pressure. And then I usually like to use a roller bandage. Put a roller bandage in their mouth and have them bite down on it and hold the tooth in place with their own personal bite pressure. So if you have a tooth that's not completely avulsed, we call this a chipped tooth, so the tooth is broken somewhere, go ahead and place that tooth in milk if it's available. So a nice little container of milk. You can wrap the tooth in gauze so that it's easier to find in the milk, and then just stick the entire unit inside the milk. If you don't have milk, try to use saline with ice, just to keep it nice and cool, but milk is preferred. So if you find yourself with an amputated body part, First and foremost, you need to control the hemorrhage. A lot of times you might have an arterial bleed depending on where the amputation actually happened. So go ahead and take the hemorrhage control steps immediately. That's our priority, because it doesn't matter if they get their body part back on if they're dead. So make sure that you treat the patient appropriately first. Apply direct pressure to control the bleeding, and if you think it is an arterial bleed, use a tourniquet. As far as the actual body part, try to wrap the amputated part in a sterile dressing and secure the dressing with self-adhesive gauze or self-adhesive gauze bandage. So this only works for like small amputations like a finger or toe or something like that. If it's an entire arm, try to wrap the part that was like the area that got severed in a sterile dressing, but you don't have to wrap, say it's at the shoulder, you don't have to wrap all the way down from the shoulder to the hand in a sterile dressing. Just where the amputation actually occurred, you need to wrap that in a sterile dressing. Once you have the body part secured, place it into a plastic bag and try to keep it cool by a cold pack. Don't apply ice directly to the body part, just like we wouldn't if the part was attached. You want to have a little bit of barrier between that and the body part, so that you don't freeze the tissue. So keep that in mind, that you do want some sort of barrier. And remember, do not immerse an amputated part directly in water or saline. That should be pretty self-explanatory. We don't want to immerse body parts that are attached in water or saline for a long period of time, but especially ones that are not attached. So if you have a genital injury, first we want to control the bleeding. There can be quite a bit of bleeding with a genital injury. They're usually highly vascular body parts. You then want to preserve any part that came off. So if anything got avulsed, you want to try to preserve it using the methods that we've talked about. And consider if that injury suggests another more serious injury happened. It's relatively rare that you have an isolated genital injury. Usually your genitals are relatively well protected. They're in area of your body that usually has an isolated injury to it. Usually has multiple injuries going on, and just one happened to cause the genital injury. So keep that in mind. Even though it might be shocking to see and might produce a lot of blood, you have to not get that tunnel vision and have to keep in mind that this could be a cause of another larger injury. It should go without saying, but you need to be calm and professional. This is where we have a lot of emotional support that's needed. Try to address and manage the wound as easily as you can, and then also keep in mind that this might be a result of a sexual assault. Especially, we see that a lot with vaginal injuries. It might be a possibility of a sexual assault, and maybe the patient might not be forthcoming with that. So try to find out how this happened. Finding the mechanism of injury is huge. All right, so moving on into burns. So burns are very painful and they're very dangerous. They can get a lot deeper than skin level structures, and we have to keep that in mind because a lot of times you're going to see the burn on the skin and you're going to be focused on that. But you have to remember there are a lot of things underneath the skin that could have been affected by the burn as well. And patients will be focused on all the pain on their skin, but you again have to be not narrow-minded and be thinking about what's underneath the skin and what could have been involved. If the burn is to the airway, that can typically cause swelling, and the swelling is usually it's a very fast onset, but that very fast onset might be delayed. So just because the patient is okay for the first 15, 20, 30 minutes doesn't mean they aren't going to have a sudden flash of swelling in their airway and all of a sudden have a massive airway obstruction. So if you have burns to the airway, that's something that we really should have ALS involved very quickly so that they can use their advanced airway techniques to treat these patients. Again, burns are very distracting, so don't let it distract you from the rest of the patient assessment, especially if it's a very grotesque burn. Make sure that you actually assess the rest of the patient and we aren't missing anything else, like possible spinal injury or fracture somewhere or other internal injuries. So just because you have a very obvious burn somewhere doesn't mean you can't finish your head to toe assessment. So as far as our patient assessment goes, we need to classify the burn. So we look at what caused the burn. So was it like a chemical burn, or was it a electrical burn, or a thermal burn? How deep is the burn, and what's the severity of the burn? So like I said, we need to find first what burned the patient. So thermal, chemical, electrical burns. Those are usually pretty self-explanatory. Again, thermal burn is where you touch something hot. So in case you didn't know what thermal meant, that's when something that's physically hot touches you, versus a chemical might not be hot, but it can burn your skin. So never assume the source of the burn. Try to ask questions to figure it out. So don't just say, oh, they're burned, they must have touched something hot. Maybe they touched a chemical they shouldn't have touched. You don't know until you ask and until you do some investigation for it. So always get your information from your observations of the scene, some bystanders, and talking to the patient. The information on the scene is huge. If you have a house fire and a patient is pulled out of that house fire, you can probably assume, or not assume, but guess that it's a thermal burn. So that was usually a good educated guess because they were pulled out of a highly thermal area. If you go to a school, to the chemistry lab, and you are dealing with a burn, that scene information will make you have an educated guess it might be a chemical burn, and you can usually back that up with asking what happened. And usually people will tell you, oh, they were playing around with these chemicals and got burned. So don't just assume. Always look at your scene information and talk to people to find out what happened. So depth of burns. We have 3 different degrees of burns. The first degree is the least amount of burn, and third degree is the more significant amount of burn. So first degree is a superficial burn. That's where we only involve the epidermis. Remember, epidermis is the outermost layer of skin. Usually you have reddening with minor swelling and pain. A great example of a first degree burn is a sunburn. Most sunburns are first degree burns. Second degree burns are called partial thickness burns. So that's where we've burned through the entire epidermis and the dermis is now damaged. This is where we have blistering happening. It's usually very deep and intense pain. And that's usually the telltale sign, is if it goes from being just red to having actual blisters. Blisters means that's going to be a partial thickness burn. So that's where we've gone from first degree to second degree, is when we see blisters pop up. And then lastly, we have the third degree burn, which is a full thickness burn. That's where we burned all the layers of skin. We usually will see black areas, and it's usually has white and dry patches surrounding that black area. And there is a significant amount of fluid loss. That's because we've lost all ability to maintain the fluid inside of our body, because we've damaged the entirety of skin. All the thickness of the skin is now gone, which is why we have an open way for us to just lose fluid straight out of our body, because we've damaged our skin. There might not be pain with third degree burns. It's usually either incredibly painful or no pain at all. And that's because the burn can burn through your nerve receptors. So if you don't have nerve endings, you won't feel anything. So you can't feel the pain if you've burned your nerves completely. So again, this will either be incredible, intense amount of pain, or it'll be no pain at all. One or the other usually. So here's a little diagram of the differences in burns. Again, usually our good gauge is superficial is just red, partial thickness is when you see blistering, and full thickness is when you've changed color to like dark or black, really. Here's a picture of a superficial burn. This is a sunburn. This is a partial thickness burn where we have some blistering going on. Here's another partial thickness burn. This is more typical of a partial thickness burn, where we have the large amounts of blistering. And this is a full thickness burn. So this, as you can see, lots of blackening. So this is where we've burned through the entirety of the skin. So when we're talking about severity of burns, we have to think about a lot of different areas. So you have to think what caused the burn, which we've already discussed. You then have to look at the body regions burned. A burned foot is a lot less significant than a burned neck or airway or face. So look at what body region was actually affected. Then you look at the depth of the burn, so first, second, or third degree. You look at the extent of the burn, so how far it goes. Then you also have to consider the age of the patient and any other injuries or illnesses. So if you have a 2-year-old that's burned, it's going to be a little bit more significant than a 20-year-old who's burned. And same thing goes if you have like a 90-year-old burned, it's going to be a lot more significant than you have if you have a 20-year-old burned. So age of the patient does matter a lot. And then other injuries or illnesses. A lot of times people who are burned have some other trauma that's going on that caused the burn. So again, we can't neglect to assess the entire patient just because you see this really gruesome burn on the outside. So one thing that we can use to help us determine the severity of burn is we have to know the percentage of body area that was affected. So we use a few different rules. The biggest one we use is called the rule of nines. So that will help us estimate the extent of the burn area. Rules of nines is something you guys do have to remember. And there's a diagram on the next slide that will show this. And in the diagram, each area that we show represents about 9% of the body surface. Something I do want to cover is if you need to estimate a smaller area, typically the size of your hand is about 1% of your total body surface area. So if you have a smaller burn, compare it to the person's hand. So if it fits one hand width, then it's about 1% of your body area that was burned. So here's rule of nines. So we divide the body up. We have, for an adult, the chest is 9%, the abdomen is 9%, the groin is about 1%, then each leg on the anterior side is 9%, and each arm on the anterior side is 4.5%, so that's half 9%, and then your head is 9%. On the posterior side, the thoracic part of your back is 9%, the lumbar and sacral part is 9%, each posterior leg is 9%, and each posterior arm is 4.5%. So you add all that up, and that should equal about 100%. With children and infants, we augment it a little bit. Children's heads proportionally are a lot bigger, so we have 18% for their head. And then we do their chest and abdomen together, so that's 18%, which you can see adult, it is 18%, we just divide it in half usually. And then each leg, both anterior and posterior, is around 7%. So we do augment it a little bit for kids, and with infants we augment it even more just because they have, again, different proportionate body sizes. So head is 18%, their legs individually are 14%, just like kids' legs are 7 on each side. Arms are 9%, and their front is 18, their back is 18. So it's a lot of information taken at once. Go ahead and pause this and study it a little bit, because this is something that you guys do need to know for guessing the amount of area, body surface area that was involved. So the reason why it's important for us to know the severity is because this will determine what the patient needs, especially if they need a burn center or not. And we need to be able to relay this information to the hospital. So you need to be able to say, like, if they have burns to their entire chest and abdomen, like the person that we saw with the 3rd degree burns in that picture, you need to say that 18% of their body surface area is burned. That will be a qualification to bring them to a burn center. So you need to be able to communicate this easily and effectively over the radio to the receiving hospital. So instead of saying, well, there's burns here, 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 and here, you need to say 27% of their body is burned. Much easier way to say that rather than trying to list all the different areas. Again, burns to geriatric patients are much more serious because they can't heal as easily. So a burn that might be moderate to a younger patient might be fatal for a geriatric patient. And like we talked about, infants and children have much greater relationship of body surface area to total body size. So that means that you have a lot greater fluid and heat loss from burned skin. So pediatrics and geriatrics burns are much more serious than the same type of burn in a normal adult. So as far as our care for thermal burns, our number one concern with any type of burn is stop the burning process. So that seems self-explanatory, but if you pull someone out of a house fire, that's stopping the burning process. And then make sure that we cool the burned area down so that we don't have superheated skin that continues to burn. So number one, stop the burning process. And that might be a test question of what's the first thing you do for a burn. Stop the burning process. Then you need to make sure that the airway is open and that they're breathing well, and then make sure that it stays open. See if there's any burns in the airway. Again, the airway can swell very, very fast and it might be a delayed reaction. So this is something we have to continually reassess. And then we complete our primary assessment and treat for shock. The biggest thing that one of the biggest things we're worried about with burns is fluid loss, because you've lost your ability to keep the fluid inside your body. So you will go into hypovolemic shock very, very quickly. You then want to have a quick evaluation of the burn, find out how serious this is. Try to not clear any debris out of the burn. If it's feasible, remove clothing and jewelry, because typically after the initial stages of the burn, the skin will swell. And if the skin swells and there's clothing and jewelry on it, that's going to cause quite a bit of perfusion issues. So if we can remove those before the skin swells, that's ideal. Keep the burned area sterile, so we try to put a sterile dressing on it and make sure it's dry. Do not put a moist dressing on. Make sure it's a nice dry, sterile dressing on the patient. If you have burns to hands or feet, again, try to get the patient's rings or jewelry off, and then separate the fingers or toes with sterile gauze pads. That's because burned skin will melt together. So if you have especially toes, which always like to stick next to each other, you melt the skin, it's going to then fuse that skin together. So if we can, in the initial stages, put sterile gauze pads between the toes and or fingers, that will help prevent that from happening. As far as chemical burns go, try to wash away the chemical with copious amounts of water. I'm talking like 20 minutes worth of water. So try to get all the chemicals off you. If it's a dry chemical, try to brush it off first. So get as much as you can off by brushing it, then flush with water. Keep in mind, if it burned the patient, it can burn you. So make sure you use all your proper PPE. This could be a hazmat situation. So don't just go in there thinking that you can do everything. Depending on the chemical, you might need to get a hazmat team in to decontaminate the person first. That being said, some chemicals do react to water, especially dry chemicals. So try to find out what the chemical is, talk to the patient and ask them about it. So while you're doing that, try to brush as much as you can off, and hopefully the patient knows about the chemical. If not, you can refer to your emergency response guidebook and find out if this is something you can use water with, because we don't want to use water and have it be a catalyst to make everything even worse. So keep that in the back of your head. Chemicals are potentially hazardous or hazmat scenes, so we have to be very careful with how we treat chemicals. So again, our number one priority with burns is to stop the burning process. So if the chemicals are on the patient's clothing, we have to get that clothing off of them. It sounds dumb, but that's part of our treatment, is to remove anything that could continue to burn the patient. So get contaminated clothing off of them. Again, apply dry, sterile dressings, treat for shock, and transport. If you have a radiological burn, this is usually few and far between. It's caused by a high level of radiation, usually over a certain amount of time that is unacceptable to the human body. It's hard for us to be able to detect this because you need specific monitoring equipment, and usually anything with radiological sources are highly monitored by people who know what they're doing. So usually this will be at like a nuclear power plant or something. So people on scene will be a valuable resource to provide guidance to how to treat these patients. Probably goes without saying, but being exposed to something that can cause a radiological burn is extremely harmful. So these patients usually need to be decontaminated first. So we are not the first step in the patient care process for these patients. We need to assure our own scene safety and make sure that we aren't exposed to whatever they got exposed to. So this is not something that we cover in EMT class, besides saying not our job. So if you ever want to get involved in that, you have to go through specialized training. So these are patients that we only see after they are fully decontaminated. So keep scene safety at the top of your head. You cannot treat someone if you get exposed yourself. As far as our injuries, they present very typically like thermal injuries. So we treat them relatively the same, even though the source is different. So it's important for us to be able to assess the severity of burns because we might need to bring patients to specialized burn centers. In the upstate New York area, the burn center is upstate. And it happens to be our trauma center too, because a lot of times someone who is burned badly has suffered some sort of major trauma as well. So that's why the hospital does both. So a burn center is a designated hospital that has a specialized burn unit on it. I've been there a few times. It's actually a very lovely unit. It has about, I think, 10 to 15 beds. Don't quote me on that, but from my memory, that's how many they have. And it's designed to keep a lot of their care very sterile, because one of the biggest things with burns is keeping a sterile environment so that we don't get a lot of pathogens entering through our opening in the skin. So, patients that need to go to burn centers. First one is a second-degree burn that's greater than 10% of the body area. This is why we have to know our rules of nines. If it's over 10% of the body area, it's going to a burn center. Any burn that involves the face, hands, feet, genitalia, perineum, or major joints, that should be going to a burn center. Third-degree burns that happen to any age group should be referred to a burn center. Electrical and chemical burns should go to a burn center. An inhalation injury, so where the airway is burned, should be going to a burn center. And then patients who have a pre-existing condition that might affect the healing process, especially like autoimmune diseases, they should be referred to a burn center. Some of these are guidelines for people who should go to a burn center after initial stabilization in another hospital. But if upstate is a option for you, if you are close enough that they're one of the closest hospitals anyway, these patients should be going to the burn center. All right, moving on into electrical injuries. So electrical injuries is where the body is damaged by electricity flowing through it, and that usually will burn you, and it disrupts your nerve pathways. You can see entry and exit burns, and it's similar to penetrating traumas. Usually the entry is much smaller than the exit. The exit is usually very large and grotesque. One of the biggest emergencies we see with electrical injuries is you disrupt your cardiac rhythm, and so respiratory and cardiac arrest are very, very possible. The electrical current can cause violent muscle contraction, so much so that pulls on your bones that the muscles are attached to so hard that it can actually fracture your bones. Electrical injuries are very severe, especially depending on the amount of voltage that goes through the body. As far as patient care goes, provide airway and breathing support, provide basic cardiac life support. Keep in mind that electricity going through your body might cause the electrical pathways in your heart to malfunction. Even if it doesn't happen immediately, it can happen later. So be ready for them to go into a lethal cardiac rhythm. So be ready to defibrillate them if that happens. Take general care for shock. Give high concentration oxygen if indicated. Take care of their spinal and hand injuries as well as any extremity fractures. Evaluate the burn sites. Cool down the burning. Remember, we're stopping the burning process. So treat it just like you would with a thermal burn. Apply sterile dressings just like you would with a thermal burn, and then transport as soon as possible. All right, moving on to a little bit of chapter review. Soft tissue injuries may be closed or open, depending on if the skin is interrupted or not. Closed injuries include contusions, hematomas, crush injuries, and blast injuries. Open wounds include abrasions, lacerations, punctures, avulsions, amputations, crush injuries, and blast injuries. For open wounds, expose the wound, control the bleeding, and prevent further contamination. For both open and closed injuries, take appropriate standard precautions, note the mechanism of injury, protect the patient's airway and breathing, consider the need for oxygen by non-rebreather mask, treat for shock, and transport. Burn severity is determined by considering the source of the burn, body regions burned, depth of the burn, whether it's superficial, partial thickness, or full thickness, extent of the burn using the rule of nines, age of the patient, and other patient illnesses or injuries. Care for burns includes stopping the burning process, covering a thermal burn with a dry sterile dressing, flushing a chemical burn with sterile water, protecting the airway, administering oxygen, treating for shock, and transporting the patient to a medical facility. For treatment of electrical injuries, be sure that you and the patient are in a safe zone away from possible contact with electrical sources. Protect airway, breathing, and circulation. Be prepared to care for respiratory or cardiac arrest. Treat for shock, care for burns, and transport. Remember that the soft tissue of the body is made up of skin, fatty tissues, muscles, blood vessels, fibrous tissues, membranes, glands, and nerves. Remember the skin provides protection, water balance, temperature regulation, excretion, and shock absorption. Remember, open or closed in reference to a soft tissue injury is dictated by whether or not the skin is still intact. Remember, closed injuries must be evaluated with consideration to underlying anatomy and the mechanism of injury. Remember, open injuries are typically easier to visualize, but they can often mask underlying injuries. Remember, burns involve immediate destruction of tissue, but also can have a long-term effect, both physically and emotionally. Remember, safety must be a key concern when treating a patient with a burn or an electrical injury. And the goal of dressing and bandaging wounds is to control bleeding and prevent infection. So some things you should think about is, does the patient have a patent airway and is the breathing still adequate? If the wound is penetrating, is there an exit wound? What is the best way to immobilize an impaled object? Is there respiratory involvement with the burn? Have we irrigated the chemical burn sufficiently? Does the electrical burn have an exit wound? Is the patient securely fastened to hold the dressing? So you have a 21-year-old male who lacerated his anterior elbow when he fell through a window. There's a lot of blood around the patient. Bystanders have applied numerous towels and washcloths over the wound, at least 3 inches thick. There are so many dressings on the patient that you can't tell if it is still bleeding. The patient is alert but pale and anxious. The radial pulse on his uninjured arm is weak and rapid. How much assessment of the wound should you do, and how should you do it without making things worse? So this is a very common thing for us to see. Typically in a patient like this, the washcloths and things that bystanders use probably are not sterile whatsoever, so we don't want to be packing that wound with something that could infect it. So it's usually appropriate to briefly take all that stuff off and then apply your own sterile bandages and dressings to that area. Be prepared to have a large dressing available and to put it on pretty darn quick. So take a brief look, like for a half second, see what type of bleeding we're looking at, whether it's venous or arterial bleeding, and then dress the wound and bandage it as needed. Keep in mind, this patient it looks like he's probably going into shock, so this might be an arterial bleed, so have a tourniquet ready to go. So key is get the not sterile stuff off, take a quick look, but be prepared to treat immediately, and be prepared to go to a tourniquet because it looks like this is a significant bleed that's causing the patient to go into shock. All right, that brings us to the end of this chapter. There's a lot that we covered with soft tissue trauma, and really the last chapter and the next chapter, between those 3 chapters, there is a ton of material. This is pretty much half of your trauma material is all within these couple chapters. So a lot of stuff to go over. Feel free to review it again. And this stuff is things that we actually do hands-on quite a bit. So this is stuff that we have to have mastered in class, because you will see it in the field, and when you see it, you have to act very quickly. Otherwise, a patient could die relatively quickly. And these are patients that are otherwise usually healthy. So these are patients that really we want to have the best outcome for, because they have a great quality of life that they could return to if they are treated appropriately. So until next time.